Okay, so this is chapter 24, Diuretic Therapy and Drugs for Renal Failure. So we're going to go over kidney function somewhat. I don't know if that's really necessary, so I'll probably be pretty quick. But we'll talk about kidney disease, renal failure, and then, of course, how pharmaceuticals are involved, since the kidney is where a lot of drugs are excreted. And then we'll spend the rest of our time talking about different diuretics. Okay. So renal regulation. So kidneys regulate fluid volume, so we know that because they regulate blood pressure, and that's fluid in the body. Electrolytes, so things like sodium, chloride, potassium, those important ions. And then acid-base balance. So we're also gonna cover some of that. So they secrete renin for the renin, remember the RAA pathway, the renin angiotensin aldosterone pathway that regulates blood pressure, erythropoietin, which stimulates red blood cell production. Remember, that's made by the kidney, so when they fail, then that's not made, or not as much of that is made as they're failing. And then calcitriol, which is also regulated. It's a kidney hormone that regulates bone. Well, it regulates calcium. It says bone homeostasis, but it kind of regulates calcium and reabsorption of calcium. Okay, so obviously, if the kidneys fail, then you can have calcium deficits too. So, kidney structure, not much new here. Two kidneys, two ureters, one bladder, one urethra. The nephron is the functional unit of the kidney, and I know we've talked about the nephron in terms of the glomerulus and filtration. We talked a lot about that in patho, but now we're going to talk a little more about the nephron. Okay, and that's where the urine is made, and that's really where fluid is regulated through that reabsorption. So we'll look at that real quick. And let's see, blood enters the nephrons and is filtered through the glomerulus. That's when it becomes filtrate, and essentially once it enters the nephron, it's going to become urine unless something in there is reabsorbed. And of course, most reabsorption happens here in the proximal tubule. So as soon as it gets filtered through the glomerulus, most of it's reabsorbed. Most water, most ions, glucose, most of that stuff is reabsorbed. Now, there's something else that is really important to drugs, and I have down here written some drugs and or their metabolites are secreted directly into the nephron tubules. What that means is that there are little pumps here along the nephron that will actually recognize certain chemical properties of drugs and then pull them right into the nephron so they can be excreted. Okay, so in some cases that's important, but I think we're going to focus mainly on what happens when these nephrons aren't there and that secretion can't take place. You know, that's just another thing that's going to leave that drug in the system. Okay, so water and molecules pass into the proximal tubule. Filtrate passes through the loop of Henle, so you have more reabsorption that's happening. Then the distal tubule, and then it goes into the collecting duct and out as urine. Okay, so renal failure. So decrease in the kidney's ability to function. It can be acute or it can be chronic. And we have up here a picture of a failing kidney, and you can kind of see these pyramids where the nephrons are just kind of wasting away, just kind of going away little by little and being replaced by fat and connective tissue. So I kind of mentioned this earlier, most drugs are excreted in the urine. So most drugs. So there are a small number of insoluble drugs that do leave through the liver in the bile. But most of the time it passes through the liver breaks them down, and then those metabolites may leave through the urine, but as long as it's in the blood, they have a chance of being excreted through the kidney. So either as the full drug or as a metabolite or a broken down product of the drug. So failure of the kidney can cause these drugs to accumulate to high levels. So we need to keep that in mind, especially for patients with kidney failure or kidney disease. So medication dosages need to be adjusted. So administering an average dose to a person with renal failure can be fatal. Elderly patients tend to have poorer renal function and may require dosage adjustments as well. And adjustments could involve drug dose, So how much drug are you giving them, or the dosing interval. So maybe instead of 3 times a day, they only need it twice a day or something like that. Creatinine clearance can help provide information about the appropriate dose. So normally the creatinine is a breakdown product of creatine. So remember, in the muscles we have creatine kinase. I don't know if you do remember, but it's another way to help generate ATP quickly. Well, the muscles are constantly breaking that creatine down, and so that happens pretty regularly at a pretty regular interval for everyone. And it's excreted at a pretty regular rate. So you should be able to see if what comes out of the kidney, so what's in the urine, if it's decreasing, if it's low, then that usually means that that your clearance is decreased. And if you think about that, if creatine or creatinine is found in the blood, and we start seeing a decrease in the creatinine in the urine, well, then you can pretty much guess that since the drug is also in the blood, that you're going to probably have a decreased amount of that drug that's also being passed through the urine. So you can kind of get an idea about that through creatinine clearance. So patients with kidney disease or taking nephrotoxic drugs need periodic monitoring. And yes, there are some drugs, quite a few actually, that are toxic to the kidney. And yet the assumption is that the therapeutic benefits outweigh that risk, and so you wouldn't want to keep them on it as long. Is probably the best, as little as possible. So acute renal failure, chronic renal failure. Acute renal failure requires immediate treatment. Accumulation of wastes and products can be fatal. Usually that's caused by hypoperfusion of the kidney. So somehow something else has happened in another part of the body where the kidneys are either not able to get the blood, or they've actually shut down and said, stop sending as much blood through that renal artery. So heart failure can do this. Dysrhythmias, so which is where the heart isn't pumping as efficiently, and so the kidneys might say, okay, well, the blood pressure's dropping, so we're going to shut down perfusion of blood to the kidneys. Hemorrhage, so if you're bleeding somewhere. And dehydration, so just a lack of fluid in general can cause that. Chronic renal failure, of course, occurs over months or years, may be undiagnosed for a long time, and usually includes, so this is kind of important, usually includes a history of diabetes or hypertension. So that's usually what's causing the chronic renal failure. But acute, it's the trick there is, the kidneys will start to fail if you don't take care of this heart failure, hemorrhage, dehydration, whatever it is. The kidneys will suffer pretty quickly. Okay, so nephrotoxic drugs may result in acute or kidney renal failure, so it's not just one or the other. It could result in either one of them. So here's a list of nephrotoxic drugs, and really this is a lot of stuff here, and we're gonna cover some of these in different sections, and so I'm not too worried about it yet. But if you look at the you can't really nail it down to any one certain type of drug, because here we have antibiotics, aminoglycosides, or streptomycin can be nephrotoxic. Antifungals, hypertension medicine, angiotensin converting enzyme, or ACE inhibitors, cancer drugs, that's going to be pretty common. Immunosuppressants, antivirals, inflammation or pain, NSAIDs. NSAIDs can actually cause renal damage as well, so that's another thing to keep in mind for long-term NSAID use. Anti-infective, diagnosis of kidney and vascular disorders, contrast agents. So a contrast agent is just something because blood doesn't show up very well. Blood and blood vessels don't show up very well in MRI or radiographic imaging systems, and so you put a contrast agent in there. But a lot of times these can be harmful to the kidney as well. Okay, so how do you diagnose it? So how do you know if your person has renal failure? So we would look at the urinalysis, presence of blood cells. A lot of these things proteins in the urine, pH changes. specific gravity, so that just means how watery it is. Is it very dilute, or is it very sort of thick and with a high specific gravity, not as much water? So that means not as much water is being excreted. Presence of ketones, glucose, microorganisms, anything that's out of range, obviously. Proteinuria and albuminuria are primary measurements of kidney function. Okay, and then here again, here's the serum creatinine. So if you look at how much creatinine is in the blood serum, and you can compare that to how much is in the urine. And by comparing those things, you can actually get an idea for what kind of excretion is taking place by the kidney. So you can see how much is in the blood versus how much is in the urine. So you can also test for renal failure by diagnostic imaging. So you can actually look at them, or you can take a chunk through a renal biopsy. Now, far and away, GFR, glomerular filtration rate, the best marker for estimating renal function. So that's kind of the go-to. And what that is, if you don't remember, is you measure the volume of the filtrate passing through the Bowman's capsule per minute. That's what glomerular filtration rate is. And of course, as more and more nephrons die, GFR is going to decrease more and more. Okay, so pharmacotherapy for management of kidney disease. So you have a kidney disease, and the kidney is not producing enough urine or something like that. So the primary treatment goals is to maintain the blood flow to and through the kidneys. Okay, so you want to make sure that they're getting blood. So you have perfusion plus you have urine production that way. Diuretics can maintain adequate urine output. Okay, so you're trying to you're trying to leave that water, and of course a lot of solutes that are going to stay in that urine. But you're trying to keep the flow moving through, because if you don't, then the toxins that are in there that are supposed to be leaving through the urine, so if the kidneys kind of say, wow, the blood pressure, we're sensing something that says that we should shut this down and we should reabsorb everything we can, then you're not going to produce as much water. You're not going to have as much water moving through, and you're going to have you can have a buildup of toxins. Okay, and of course maintaining electrolyte balance. You want to have your sodium, potassium, chloride, calcium, magnesium, all those things in the right levels so the body can use them. So attempts to manage cause, effects, or source of the dysfunction. So the cause of the dysfunction, the effects, and the source. So cause and source could probably be kind of the same thing. But if it's being caused by hypertension or heart failure, then you want to use some kind of drug to treat the hypertension or heart failure. Maintain red blood cell production through the lack of erythropoietin. Okay, so you don't want someone to become anemic. And so you can kind of bypass the kidney's responsibility in there and make the body make more red blood cells. And then of course dietary management. Dietary management is going to it's kind of a big deal. We aren't going to talk about it as much. We are a little bit, but it's if you don't have enough potassium, then you might have to take potassium supplements. So protein, breakdown products of protein can be toxic. So if your kidney is having a hard time excreting uric acid or something like that, then so if it's having a hard time with the breakdown products of proteins, then the easiest thing would just be to not have as much protein. We usually get too much protein anyway, and so if your kidneys aren't able to handle it, reduction of sodium, potassium, phosphorus, magnesium, anything that's kind of out of spec, so to speak. Okay, so pharmacological management. So this is from your book. Rather than rewrite all these things, I just kind of left the whole chart in here. I did highlight some things though. So anemia, whoops, there we go. Everything just went haywire. Boom, boom, there we are. Okay, so, and somebody's not cooperating, and it's not me. Okay, so epoetin alpha. So that's your erythropoietin substitute, so to speak. It's going to help with that anemia. Hyperkalemia, KXLate. Um, so that's the pharmaceutical treatment. But of course, you can see on a lot of these that, even though I didn't highlight it, dietary restriction of potassium. If if your kidneys aren't able to adequately excrete potassium, then you just try not to take as much potassium. But there are also binders that so this KXLate will actually prevent absorption of potassium in the gut. Hyperphosphatemia, so phosphate binders, such as calcium carbonate, something that just kind of reduces the phosphate. And of course, there's your dietary for hypovolemia. Hypovolemia just means you have too much fluid. So too much fluid. Remember, sodium is an osmotic. Controls the osmotic potential, how much fluid is in your body, so you can restrict sodium. Loop diuretics that we'll talk about, thiazide diuretics that we're going to talk about, both of these, loop diuretics and thiazide. Hypocalcemia, okay, reversing hyperphosphatemia. So these are kind of related. We aren't getting into the mechanisms of that just yet, though. And then metabolic acidosis. If the kidneys can't get rid of the acid, then you may have to correct your pH. So sodium bicarbonate, we'll talk about that when we talk about fluid handling by the kidneys. Okay, so this is what we want to really talk about, diuretics. So increasing the rate of urine flow. This is what diuretics do. Okay, so you will produce more urine when you are on a diuretic. At least that's the plan. If you don't, then something else is wrong. So why do we want to excrete the excess fluid? Hopefully you already know the answer to that, because fluid is pressure. Hypertension, heart failure, kidney failure, if your kidneys aren't doing it themselves, if they're reabsorbing too much water, or if not enough water is getting there, then you want to kind of change that. You kind of want to pull the water through here to keep it moving very fast. And if you can, I'll do it over here because that's mostly where it happens. So if you can reabsorb more of that water, then that's going to kind of keep that force on to keep you producing. So if you want to stop the reabsorption, I guess I said reabsorb. If you want to stop the reabsorption of those of that water and those particles, then you're going to pull more water through, and that's going to keep the flow a little better. And so hopefully that makes sense. So hypertension, heart failure, kidney failure, liver failure, or cirrhosis. A lot of times you get like ascites in a cirrhotic liver. There'll be some ascites or fluid buildup. Pulmonary edema. So again, you're just trying to reduce fluid because fluid is building up in places that fluid shouldn't be building up. Okay, so that's another use of these diuretics. Okay, so there are loop diuretics, thiazide diuretics, and potassium-sparing diuretics. These are the ones we're going to spend most of our time talking about. And you're going to have to know some of the prototype drugs for those. So we'll start with loop diuretics. Loop, or high ceiling as it's sometimes called. I usually hear it called loop, but high ceiling is the same thing. They are the most effective. Now that doesn't mean they're always the best choice. By most effective, that means that they're going to produce more urine. Okay, so but sometimes you don't necessarily want to take a sledgehammer to it. You want to be a little bit more mild. But these are the most effective. Mechanism of action: blocks the reabsorption of potassium chloride in the loop of Henle. So here we have our picture again, and in the ascending loop of Henle, there's this thing called the sodium potassium chloride cotransporter that pumps potassium, chloride, and sodium. Now pay attention to those. Sodium and potassium in particular. Chloride just kind of goes where sodium goes. But potassium sodium are usually reabsorbed back into the body in the ascending loop of Henle. Loop diuretics stop that from happening. So now what does that mean? That means that those particles are staying in there, which means water is going to stay in, okay? Because water through osmosis is going to, it's going to follow those particles. And if those particles don't leave, the water doesn't leave. So what that means is what gets excreted is sodium, chloride, potassium, and water. Okay, so more of that is going to be excreted. Now, you already probably can figure out that if we're excreting our potassium, there's a good chance that we're going to have hypokalemia, or a low potassium. And that does happen in some cases, so that's something you have to monitor. So leaving these ions in the nephron causes excretion of more water and the ions, of course. Primary use to reduce edema. Okay, so pay attention to this. Primary use to reduce edema associated with heart failure, hepatic cirrhosis, or renal failure. Okay, so we're trying to reduce fluid that's building up in another place. Furosemide, and this is your prototype drug, furosemide, so you're going to be very familiar with that. And torsemide are also approved for hypertension treatment, and of course you're going to that's going to be a dosage issue depending on that severity. Okay, so again, I left this here. So this is the table that's in your book, or there are lots of these tables in your book. And the one with the little pill by it is your prototype drug, and that's the one that we're going to focus on the most. So furosemide, it's also called Lasix. So furosemide, Lasix, and you can kind of see bumetanide, it's got the IDE, so mide, it's nide, but torsemide. So always pay attention to that. You'll figure it out probably anyway, but these suffixes, these endings, are a lot of times, sometimes they're not, but most of the time these endings can kind of give you a good clue as to what the class of the drug is. Some of them are just made by the molecule that it is, ethylenic acid. That's just what it is. Okay, so adverse effects, minor hypokalemia, no surprise there since we're getting rid of potassium. Postural hypotension, so that means when you stand up. So this person might, they might want to be a little bit more careful about standing up. Well, not that they shouldn't stand up, but they need to stand up more slowly because they could lose blood pressure very, very quickly and pass out. So they need to be aware of that. Tinnitus, these drugs, the hair cells in the ear tend to be pretty sensitive to a lot of different drugs, so it's always good to pay attention to that. Hearing loss, and sometimes that hearing loss can be permanent in several different drugs, so that's something to pay attention to. Nausea, diarrhea. Anyway, and then just more severity. Significant hypokalemia, blood dyscrasia just means stuff is building up in the blood. Dehydration, sure, you're getting rid of more water. If they're not replenishing that water, they're going to get dehydrated. Ototoxicity, so there's the ear thing again. Electrolyte imbalances. Circulatory collapse because you've dropped the pressure too much could also be a problem. Okay, so this, we're not going to go over this. I leave it in your slides, so in case, I don't know, in case you want to print it off or something like that, you can. This, like I said, I'm not going to go through all this, but you do have to know a lot of detail, okay, on these prototype drugs, okay, including interactions to the best that you can. Okay. All right, so what are some things to watch out for or to prepare for with loop diuretics? Obtain a baseline, periodically monitor lab values, weight. Sure, weight. If somebody is gaining a lot of weight or losing a lot of weight very rapidly, it's usually water. And since you're messing around with water movement, water excretion, then that's something that's going to tip you off very quickly. Current level of urine output, yeah, makes sense. Monitor electrolytes, especially potassium, but sodium and chloride as well. Blood urea nitrogen, creatinine, uric acid, blood glucose levels, all of these things. Assess for circulatory collapse, dysrhythmias, hearing loss, there's that again. Renal failure, anemia, So all of the things that are kind of involved with what you're doing. Monitor for side effects: orthostatic hypotension, hypokalemia, hyponatremia, polyuria, too much urine. Observe for rash or pruritus as well, because that can always be an indication that something else is going on with the kidneys or even with the liver. Teach patients to take diuretics in the morning, change position slowly. Remember, that's that orthostatic hypotension. And of course, for them to monitor their weight. If they see a big drastic change, then that may mean they're either excreting too much or not enough water. Okay, so patients should take potassium supplements if they have to, and consume potassium-rich fluids. Of course, that's again because you're excreting more potassium. Okay, so those were loop diuretics. Thiazide diuretics, that's a different chemical class. These are the largest, most commonly prescribed class. Okay, so they're not as effective, but they kind of fit the profile for what a typical person would need. So mechanism of action, they also block sodium reabsorption from the distal tubule. Okay, so what they do is it's an exchange mechanism where sodium or it's not an exchange. Let's see. It's a not really a co-transport, but as sodium is reabsorbed, so is potassium. So these things kind of move together. Sodium and potassium both move together. But when you block the reabsorption of sodium, you tend to also stop the reabsorption of potassium. Okay, so we're going to talk about potassium-sparing drugs, which those are that is based on an exchange, but these are not. And so when you block the reabsorption of sodium, you're also blocking the, you're also going to cause more potassium and water to be excreted. Okay, so primary use to treat mild to moderate, but it does happen in the distal tubule, which is shown here. Used to treat mild to moderate hypertension, also indicated to reduce edema associated with heart, hepatic, and renal failure. Okay, so it kind of depends on severity. Less effective than loop diuretics because much of the sodium was reabsorbed by the NKCC. So they're not as effective because they're a little bit further along in the nephron, and a lot of that sodium has already been reabsorbed. So by the time they're blocking reabsorption, there just isn't as much. That's why these loop diuretics are way more potent. Okay, or effective. Let's see, not effective in patients with severe renal failure. Okay, so because they're less effective than the loop diuretics. All right, so again, here we have, this is the table, thiazide and thiazide-like diuretics, and your prototype drug is going to be hydrochlorothiazide or microzide. Okay, hydrochlorothiazide, microzide. Okay, and a lot of these have the zide endings, not all of them, but a lot of them do. Chlorothiazide. So hydrochlorothiazide, microzide. Adverse effects: minor hypokalemia, yes. Significant hypokalemia or more significant adverse effects: dehydration. It's kind of the same things. Hyperglycemia, coma. So that can really progress to that. Okay, and this is your prototype drug, so make sure you look at this and go over this. Like, I'm not going to read this to you, but you do have to know that. Potassium-sparing diuretics. So we've been talking about how potassium is leaving. So there are potassium-sparing diuretics, and this is where we have an exchange process. So sodium is being reabsorbed. So if this is your nephron over here and this is your blood over here, so sodium is being reabsorbed, and potassium, this is what's normally happening, and potassium is being secreted. That's normally what takes place when everything is happening naturally. But if we block this exchanger, it's the sodium-potassium pump, that's all it is. But if we block this sodium-potassium pump, then what we do is we block sodium from moving out and we block potassium from being excreted. I hope that makes sense. The important thing to remember, though, is that you're blocking sodium. Sodium is staying in here in the nephron, and potassium is staying in the body by blocking this exchange. And so, so the advantage is you have diuresis, but you're not affecting blood potassium levels. And it really does it by blocking aldosterone. If we wanted to get into all the mechanisms of this, it really, aldosterone, it really makes sense that by blocking that sodium-potassium exchange in the distal tubule, or by blocking aldosterone, that you're going to have less reabsorption of sodium, more excretion, but your potassium is going to stay. Okay, so spironolactone, or aldactone is the generic name is spironolactone, the trade name aldactone. That's going to be your prototype drug. Adverse effects, minor hyperkalemia. So now, of course, you've got the chance that potassium levels are going to go too high. Headache, fatigue, gynecomastia, especially with spironolactone. So that's can be a problem. Dysrhythmias from the hyperkalemia. So that's something that you really want to watch. Always watching those potassium levels for dysrhythmias. Dehydration, hyponatremia, agranulocytosis, other blood dyscrasias. So you can kind of go through that. So again, here's your prototype drug sheet, and for spironolactone or aldactone, and so you can kind of go through that. So now there are some other miscellaneous diuretics, cannot be classified as loop, thiazide, or potassium sparing. So we've gone through those, and have limited and specific applications. So here are, the first one we're going to talk about is carbonic anhydrase inhibitors. It works more in the proximal tubule. Carbonic anhydrase, hopefully you remember that if you combine, this is how pH is kind of regulated by breathing, but if you combine carbon dioxide and water, then you're going to make carbonic acid. The enzyme that does that is called carbonic anhydrase. That's all this is. Now, that sounds like a pH issue, and it is, but the thing is, and we're not going to get into all the mechanisms, but these are all related. I mean, when you have hydrogen, you have sodium, and you have potassium, and they all kind of depend on the concentration of one another to go where they're supposed to go. So by blocking the production of bicarbonate and hydrogen, you're leaving more of these ions in the nephron, to be excreted. So it does work as a diuretic. However, these have pretty, like I said, have pretty specific uses. So, for example, acetazolamide diamox. Let's see, primary use to decrease intraocular fluid pressure. Okay, so this is not, we're not looking at cardiac, we're not looking at renal in this case. So, so you should just be kind of be aware of these. Osmotic diuretics. Osmotic diuretics just means you put something in the blood that can't be reabsorbed. So it goes into the nephron, and since it's too large usually to be reabsorbed, then it just is going to pull more water with it. That's just the way osmosis works. Pulls more water with it. So we just call it an osmotic diuretic. It's just something that that increases that osmotic pressure, but just by being a particle that can't be reabsorbed. Okay, so increases osmotic potential. Mannitol is not reabsorbed in the nephron tubule. So that's kind of a rule. It can't be reabsorbed. Otherwise, it would just be reabsorbed, and the water would follow it out, back into the body, out of the nephron. So primary use to reduce intracranial pressure due to cerebral edema. So this is our use here. So again, we're not talking about cardiovascular, and we're not talking about renal. We're talking about reducing pressure from cerebral edema. So also used to maintain urine flow and prolonged surgery, acute renal failure. So there we go. So acute renal failure, severe renal failure. When you kind of get desperate, you just need more urine production. Can worsen edema, used with caution only when other drugs are ineffective. Okay, so here they are. more something to be able to recognize, be aware of. I don't have a prototype drug sheet for them, but acetazolamide, glycerin, mannitol. So really these are the ones that we just talked about. Acetazolamide, mannitol, or osmotrol. Okay. All right, so adverse effects, fluid and electrolyte disturbances, dehydration, obviously, because we're getting rid of fluid, orthostatic hypertension, hypotension, potassium and sodium imbalances. So the role of the nurse in management of renal failure and diuretic therapy, careful monitoring of patient's condition. Okay, so all of the things that we kind of have already talked about, so you're going to have to be aware of all of those symptoms and what could be a problem. Providing education related to the prescribed drug management, obtain medical drug, dietary, and lifestyle history. You got to know what they're eating. You have to know what other medications they're doing. How much water do they drink in a normal day? That kind of thing. What kind of fluids do they take? Assess patient's weight, very important. Intake, output, skin turgor, moisture, so how dehydrated may they already be. Vital signs, breath sounds, presence of edema. So I'm going to go through these next things pretty quickly because we've kind of, let's see, I think we've already covered that for loop diuretics. Let me go back and check. Yeah, we've already covered that for loop diuretics, but I do want to, and I'll probably rearrange these when I upload these slides. But thiazide and thiazide-like diuretics obtain baseline, monitor periodically. Lab values, weight, current level of urine output, so kind of the same thing. Electrolytes, especially potassium, sodium, chloride, prior to loop diuretic therapy. Monitor BUN, the blood urea nitrogen, serum creatinine, uric acid. Uric acid is actually more important for thiazide because uric acid is what forms urate crystals in the toes, usually for gout, so to cause gout. And so reabsorption of uric acid can happen a lot with thiazide. Increased potassium loss may occur in use with digoxin. May reduce effectiveness of anticoagulants, antidiabetic drugs. Okay, so we'll talk about some of those drugs at some point. Increased risk of lithium toxicity when taking thiazide diuretics. Well, lithium is similar to sodium, and lithium is used to treat bipolar disorder, so yeah. Allergies to sulfa-based medications can indicate hypersensitivity. Used with caution in pregnant or lactating women. So a lot of these things are going to be covered under the drug sheet. Teach patients to use sunscreen to decrease photosensitivity, take potassium supplements if ordered, consume potassium-rich foods, report tenderness or pain in joints. And then the last one here that we'll talk about, this is our last slide, potassium-sparing diuretics. The advantage, they don't have hypokalemia. That's the point. Still critical to assess potassium and sodium, just for different reasons. Because you're looking to make sure it's not getting too high. Blood urea nitrogen, serum creatinine again, so that's going to tell you about your kidney function. Adverse effects, hyperkalemia, so we talked about that. Muscle weakness, impotence, amenorrhea, gynecomastia. Patients taking lithium or digoxin, so we saw that earlier. Increased risk for toxicity, spironolactone contraindicated for pregnant or lactating women. Avoid use of potassium-based salt substitutes. When in direct sunlight, use sunscreen. Avoid performing tasks that require mental alertness. Yeah, that's a way to go. Do not eat excess amounts of food high in potassium. And that's it. I will rearrange these and then upload them so you have them.